Can you say some benign tumors of bone? What are the benign tumors of bone? আরে বল, কিছু তো বল, প্যাথোলজিতে পড়েছিস তো, এক এক করে বল। হ্যাঁ, osteochondroma. আর giant cell tumor is a benign or malignant? Benign. আর কি হতে পারে? What are the other common bone benign tumors? প্যাথোলজিতে পড়ানো হয়েছে, like bone cyst, aneurysmal bone cyst, simple bone cyst, then fibrous dysplasia, osteoid, osteoma. So these are the benign bone tumor. So today I will discuss about two important benign bone tumor for your theory purpose, practical purpose, and for X-ray purpose. So first is exostosis or osteochondroma. Exostosis or another name is osteochondroma. So it is the most common benign tumor. Okay. This is the most common benign tumor. Male female predominance is almost equal. It is 1.5:1. In some book it is written 1:1, but you tell 1.5:1 male female ratio, and it is most common in the first 2 decades of life. It is most common in immature skeletal. Later you know why it is more common in. So this is this tumor usually occurs in children or in immature skeleton. And the most common site, eta mone rakbi, the most common site of osteochondroma is around the knee joint. Distal femur, then proximal tibia, and then other bones. Other bones like proximal humerus, distal radius, or in proximal fibula. But most common is around the knee joint. Distal femur followed by proximal tibia. Other name is osteochondroma and diaphyseal achalasia. এই দুটো নাম কিন্তু মনে রাখতে হবে, osteochondroma and diaphyseal achalasia. So what is the etiology? Why exostosis occurs? So basically it is an aberration of growth. It is due to disturbance of the growth of a bone. It is an aberration of growth. Some cells at the margin of growth plate, they begin to grow centrifugally rather than normal, which is longitudinal. So usually, what is the role of growth plate? It is the role of growth plate is for longitudinal growth of the bone. But some cells in the growth plate, some peripheral cells or outsider cell in the growth plate, they start to grow centrifugally. Okay. As the longitudinal growth continues in the rest of the bone, the exostosis gradually moves away towards the diaphysis. So actually the growth of exostosis, it started from the growth plate. Okay. But when there is longitudinal growth of the bone occurs in normal fashion, the exostosis moves away towards the diaphysis. পরে সব বলে দিচ্ছি ডিটেইলস। Exostosis point towards the diaphysis, and when the normal growth stops, the growth of the exostosis also stops. It does not grow after the maturity of the skeleton. বুঝতে পেরেছি সেটা? আচ্ছা। So what happened in this formation of exostosis? So the growth plate, which is responsible for the longitudinal growth of the bone, some amount of cell or some amount of energy is used for the centrifugal growth. So the longitudinal growth is hampered, or longitudinal growth is some amount of jeopardize is there. So longitudinal growth is sacrificed. So always there is some amount of shortening of the effective limb. When a patient comes to you with a exostosis of distal femur or proximal tibia, you eventually found some amount of limb shortening, because here the longitudinal growth sacrificed for the centrifugal growth. And sometimes this exostosis, actually exostosis may be a single exostosis or it is a multiple exostosis. Single exostosis is not genetically related, but multiple hereditary exostosis or multiple exostosis in different areas of bone, it is a genetically related. It is a autosomal dominant disorder. It is very common, not uncommon, it's quite common. You can find it some person accidentally. Usually these are asymptomatic. So hereditary multiple exostosis is an autosomal dominant disorder, and chromosome 8, 11 and 19 is responsible for this hereditary multiple exostosis. 8, 11 and 19. And chromosome is very important. Why? Because if hereditary multiple exostosis is due to chromosome number 8 and chromosome number 11, it may undergo sarcomatous change. So it may undergo malignant change. And there is continuity of the cortex and medullary cavity. The tumor, in the tumor, the cortex and the medullary cavity is continuous with its mother bone. The cartilage cap is present over the exostosis. The exostosis, it contains a cartilaginous cap, and over that cap there is a bursa. So the exostosis not only composed of the bony mass, it also has a cartilaginous cap or cartilage cap, and it is also very, very important for the diagnosis of malignancy. Later I will discuss. So this is the osteochondroma. So or exostosis. You see the growth starts from near the growth plate. The growth of the osteochondroma, it starts near the growth plate, and as there is longitudinal growth of the bone occurs, it moves towards the diaphysis. So the exostosis always pointed towards the diaphyseal region. And you see in exostosis, the medullary cavity and the cortex is continuous with its mother bone or with its parenteral bone. What are the types of exostosis? Now, exostosis can be of two types, pedunculated and sessile. So what is pedunculated or what is sessile exostosis? So this is a X-ray of exostosis of distal femur. Is it a skeletally mature or immature? Skeletal mature bone or immature bone in this X-ray? It is a immature. Why? Because the growth plate, you can see the growth plate. So it is going to be fused. It is about 16 or 17 years of old person. So you see the two types of exostosis. One is pedunculated. So this is the pedunculated exostosis, and that is the sessile exostosis. So what is pedunculated? That means the bony tumor, the tumor mass, it is connected to the bone with a thin stalk. It is connected to the bone with a stalk. That is pedunculated. Another is sessile. Sessile means broad base. The tumor is connected with the bone with a broad base. So pedunculated, where the tumor is connected to the bone with a stalk, and sessile when the base of the tumor is broad. What is this picture? This is the hereditary multiple exostosis. This is the X-ray of hereditary multiple exostosis. You can find multiple exostosis at different sites. Next, clinical features. So the clinical features of exostosis and benign bone tumor are the clinical features of all benign tumors are similar. Okay, you have to remember the clinical features of a benign bone tumor. আচ্ছা, patient commonly present with swelling which is bony, hard, smooth surface, variable. এই আওয়াজ করিস না পেছন দিকে। Patient commonly present with a swelling which is bony, hard, smooth surface, variable in size, well defined margin and not attached to the skin and superficial structure. Okay, first of all it is a bony hard swelling. Eta first of all bolte hobe, it is a bony hard swelling and the surface of any benign bone tumor it is regular, so smooth surface, and the benign bone tumor never invade the soft tissue, surrounding soft tissue, or it never involves the overlying skin. So the skin condition will be normal and there will be no soft tissue and it is not adhered to the soft tissue. Okay. So bony hard, smooth surface, variable in size and well defined margin, not attached to the skin or superficial structure. There is shortening of the affected limb. Previously I discussed because the longitudinal growth sacrificed for the lateral growth or the centrifugal growth. And another common presentation of this exostosis, it is the deformities. Why deformity occurs? Because exostosis arises from the growth plate. So what happens, like if the exostosis arises from the lateral corner of the distal femur growth plate or the medial corner of the proximal tibia growth plate, so what will happen? So there will be disbalance of growth between the two ends of the growth plate. So very commonly or most of the many times exostosis is responsible for the deformity of the limb because aberration of the growth in the different end of the growth plate. It may lead to genu varum. What do you mean by genu varum? Genu means knee, varum means inward deviation. Okay, genu varum, genu valgum, dorsolateral bowing of the radius, ulnar deviation of the wrist. Genu varum, genu valgum, এটুকু মনে রাখলেই হবে। Next is the mechanical obstruction of the joint or restricted joint movement. Why mechanical obstruction? Because if a exostosis arises from the posterior aspect of the distal fibula or the posterior aspect of the proximal tibia, what will happen? It will do mechanical obstruction of the knee joint. The patient cannot bend the knee fully. And is osteochondroma painful or exostosis painful or benign bone tumor is painful? No. Benign bone tumor or osteochondroma is not a painful. So why pain occurs in osteochondroma? In sometimes osteochondroma patient present with a pain. When? First of all, if the bone tumor is transformed to a malignant one, if there is malignant transformation of the benign bone tumor, the pain can occur. Number two, if there is any fracture, pathological fracture, but here usually the fracture occurs at the base, at the stalk. Usually the fracture at the base is very uncommon, but in pedunculated osteochondroma, the stalk is thin, so there is chance of fracture at the stalk. So if there is a fracture in the stalk, it can lead to pain. Or I have told that osteochondroma not only composed of bony mass, also have a cartilaginous cap and a bursa. So if there is inflammation in the bursa or bursitis, it can lead to pain. Or osteochondroma mass is so large that it do a neurological compression. So in that case it can also cause pain. তাহলে তিনটে বলতে হবে when pain occurs in osteochondroma. Number one is the malignant transformation. Number two, fracture at the base of the osteochondroma. And number three, if there is any bursitis over the tumor, it can cause painful condition to osteochondroma. Now, investigation. So, in any bone tumor, you have to do two investigations at least. One is X-ray of the affected part, AP and lateral view. Another is the MRI. Achha, in your exam, it is also given as a short note what are the radiological features of osteochondroma. So radiological features means the features you found in X-ray and also the features you found in MRI. So radiological features key, it is a surface lesion. Surface lesion means it is outside the bone. So it is a surface lesion. Osteochondromas are surface lesion. They grow outside from the bone surface. Bony radiopaque mass with a well-defined margin. Bony radiopaque mass with a well-defined margin. Well-defined margin, it is a characteristic features of benign bone tumor. Then metaphyseal location. It is a metaphyseal location and it pointed towards the diaphysis. Cartilage cap. Cartilage cap you may not found in X-ray. It is very difficult to find in X-ray. It is the features of MRI. It is covered with a layer of cartilage. Sessile or pedunculated. Osteochondromas can be sessile, that means the broad base, or pedunculated, that means the tumor is attached to the bone with a narrow stalk. And irregular and heterogeneous calcification. Irregular and heterogeneous calcification, it can occur either in degenerative changes or in malignant changes. I have not written the malignant changes, it can occur in degenerative changes or in malignant changes. Now the MRI. MRI is the best imaging modality to assess the thickness of cartilage cap. Okay. So why we are emphasizing the word cartilage cap? Because it is very, very important to detect the diagnosis of malignancy. Whether the tumor is transformed to malignancy or not, we can detect it by MRI, by the thickness of cartilage cap. So MRI is the best imaging modality to assess the thickness of cartilage cap. Presence of edema, spelling mistake, presence of edema in bone and the surrounding soft tissue, okay, and visualizing of the neurological structure. So MRI te ki kora details information about the tumor, and you have to see the tumor and the surrounding soft tissue, and you can also get a idea about the neurovascular involvement from the MRI. And in osteochondroma, the cartilage cap thickness in MRI is very, very important to detect whether the tumor is malignant potential or not. In MRI, if the cartilage cap thickness is more than 2 cm in adult, or if the thickness is more than 3 cm in child, better to say immature skeletal, then it is a strong indicator for malignant transformation of osteochondroma. Because the cartilage cap thickness is more than 2 cm or the cartilage cap thickness more than 3 cm in a skeletally immature bone, it indicates it is undergoing malignant transformation. So you have to do prompt treatment. So MRI has a huge role in the diagnosis of malignancy. So MRI তে কিরকম দেখা যায় cartilage cap? এটা কি MRI? T1 weighted image or T2 weighted image? ওদিকে তো গল্প করে যাচ্ছিস, বলতো এটা T1 weighted image না T2 weighted image? MRI এটা বলতে পারবি T1 or T2? তো এটা নিউমোনিক্স বলেছিলাম WW World War II WW2 water is white in T2 weighted image. তাহলে এটা কি হতে পারে MRI-টা? MRI দেবে না, তাও আমি জানার জন্য বলছি কি দেখি। সো ইট ইজ এ T2 weighted image. Why? আচ্ছা, এখানে ওয়াটার কোথাও দেখতে পাচ্ছিস? ওয়াটার পাবি না দেখতে। Because the great vessels, you see some vessels are there behind the bone. So these great vessels are white. Okay. So that means the water is white. It is a T2 weighted image. And what cut is this? It is a sagittal section, coronal section, or axial section. Sagittal কি, coronal কি, axial কি? বলতে হবে it is a axial section. Sagittal section মানে কোনটা? এটা হচ্ছে sagittal section. Coronal section, this is the coronal section. আর axial section, এটা হচ্ছে axial cut. T2 weighted image, axial cut. But in axial section, it is very difficult which bone is this, because you can find only the axial cut of the bone. But I think it's a distal femur. Why this is a distal femur? Because this is the MRI of a limb and it contains only one bone, একটাই bone আছে. Either it is humerus or femur. But the vessels, the great vessels like popliteal artery and popliteal vein, these are lying behind the femur. So what is the position of femoral artery in relation to the femur? Femoral artery and femoral vein lies medial to the femur. But through the Hunter's canal or adductor canal, it enters into the posterior compartment. Okay. So now, so here the great vessels are lying posterior to the femur. So probably it is a axial MRI of a distal femur. So you see, this is the distal femur, and this is the bony growth. This is the exostosis, and this is the continuity of the cortex, and this is the continuity of the medullary cavity. And this high signal intensity is the cartilaginous cap. High signal intensity in T2 weighted image. What is the thickness? 4.5 millimeter. That means it is a benign tumor. It is not a malignant tumor. So cartilage cap, it appears high signal intensity in a T2 weighted image. আচ্ছা বলতো এই স্ট্রাকচারটা কি? এটা তো পপলিটিয়াল আর্টারি, পপলিটিয়াল ভেন। এই স্ট্রাকচারটা কি? এটা একটা গ্রেট ভেসেল, বড় ভেসেল। কি এটা? হ্যাঁ বলেছিস ঠিক, শুনতে পেলাম। এই তো স্যাফিনাস, গ্রেট স্যাফিনাস। নাও ট্রিটমেন্ট হচ্ছে, the treatment of exostosis is conservative. Most of the cases it is conservative and observation of the tumor. Another treatment is excisional biopsy. You have to remove the tumor and send it for biopsy. এটাকে বলা হয় excisional biopsy. And when you do the excisional biopsy, you have to take some amount of periosteum from its mother bone. এটা মনে রাখবি, excisional biopsy including the overlying bursa and periosteum of the bone at its attachment. So what is the indication of surgery? So indication of surgery, suspicious of malignancy. Okay, suspicion of malignancy. Jeopardizing the normal function or activities of daily life due to mechanical obstruction of the joint or due to neurovascular deficit. Okay, example ki neurovascular deficit like proximal tibia osteochondroma, a proximal fibula exostosis, proximal fibula exostosis or proximal fibula osteochondroma, it can lead to compression of the common peroneal nerve. So the proximal fibula exostosis, why it can lead to foot drop. In that case you have to do surgery. Other deformities, for correction of the deformity you have to do corrective osteotomy. And if single exostosis is present, if patient wants or if there is some cosmetic problem, you can also remove it. So number one, malignancy. For malignancy invariably you have to do surgery if you suspect a malignancy. Next, if the tumor jeopardizes the normal daily activity due to mechanical obstruction of joint or due to compression over the neurovascular structure. Third is deformity. You have to do correction of the deformity with corrective osteotomy. And last is the cosmetic problem. If single exostosis is present, you can remove it. So which exostoses are prone to develop malignancy? It is also asked in examination. Multiple exostosis. Usually hereditary multiple exostosis are more prone to develop malignancy. The chance of developing malignancy from hereditary multiple exostosis is 15 to 20%. But the chance of development of malignancy from a single exostosis is only about 1%. So multiple exostosis. Next is the sessile variety. Sessile variety are more prone to develop malignant change than pedunculated variety. Then proximal exostosis like scapular exostosis, pelvic exostosis or proximal humerus exostosis are more prone to develop malignancy than the exostosis in the distal tibia, a distal femur or proximal tibia or proximal fibula. And if the exostosis, এটা MCQ আছে, when the exostosis undergo a malignant change, it will form chondrosarcoma. Chondrosarcoma, এটা মনে রাখতে হবে। আচ্ছা, আরেকটা কোশ্চেন প্র্যাকটিক্যালি জিজ্ঞেস করে, why the clinical size of exostosis is more than its radiological size? এটা বলতে পারবি? এটা কিন্তু জিজ্ঞেস করে, why the clinical size of exostosis is more than the radiological size? You found the exostosis is quite big, you palpate the exostosis is quite big, but it is in the X-ray it is small. Why? Very good. Because the exostosis not only composed of the bone mass, it also composed of cartilage cap and the bursa overlying the cartilaginous cap. Okay, so exostosis plus the cartilage cap plus the bursa. But in X-ray, you can only found the bony mass. It is sudden rapid growth of mass, number one. Usually benign tumor, it is a slow growing tumor. It is a slow growing tumor and long duration of swelling is there. If there is sudden rapid growth of mass, you can suspect malignancy. Number two, growth after skeletal maturity. I have told that osteochondroma or exostosis stop growing after skeletal maturity. After the stoppage of longitudinal growth of a bone, exostosis will not grow. But if the exostosis grow after the skeletal maturity or reappearance of growth in the adult or after skeletal maturity, leads to suspicion of malignancy. Then sudden appearance of pain. Sudden appearance of pain, skin, but you have to differentiate the pain from other condition. কি বলেছিলাম? Fracture and bursitis. Skin changes. The skin condition over a benign tumor, it is normal. Okay. So what are the skin condition of a malignant tumor? The skin will be stretched, shiny, hot, and there will be superficial venous engorgement. Eta mone rakhi, the skin over a malignant tumor, it is stretched, shiny, hot or warm, and there will be engorgement of superficial vein. Next, X-ray, stipple calcification of cartilaginous cap. So there will be heterogeneous calcification or stipple calcification of cartilage cap. Lytic area in bone. So in MRI, the thickness of cartilage cap, irregular margin, heterogeneous calcification, and adjacent soft tissue involvement. These are the features of malignant tumor. Irregular margin, heterotrophic calcification or irregular calcification, or adjacent soft tissue involvement. These are the features of malignant bone tumor. আচ্ছা, নেক্সট ইজ জায়ান্ট সেল টিউমার। এটা প্যাথোলজিতে পড়েছিস, জায়ান্ট সেল টিউমার। আচ্ছা, সো হোয়াট ইজ এ জায়ান্ট সেল টিউমার? এটা কি বিনাইন টিউমার না ম্যালিগন্যান্ট টিউমার? অনেকে কনফিউজ হয়। ইটস এ বিনাইন টিউমার, কিন্তু মনে রাখতে হবে যে জায়ান্ট সেল টিউমার ইটস এ বিনাইন টিউমার বাট ইট ইজ এ লোকালি অ্যাগ্রেসিভ টিউমার। জায়ান্ট সেল টিউমার ইজ এ বিনাইন টিউমার বাট লোকালি অ্যাগ্রেসিভ টিউমার অ্যান্ড ম্যালিগন্যান্ট পোটেনশিয়াল। তিনটে কথা মনে রাখতে হবে। নাম্বার ওয়ান, benign. Number two is locally aggressive tumor. Number three is a potentially malignant. So it is a benign, locally aggressive tumor with potentially malignant. যখন clinical features পড়বি, giant cell tumor না is between that benign tumor and malignant tumor. আচ্ছা, it is also known as osteoclastoma. Why? Pathology. কি থাকে জায়ান্ট সেল টিউমারের প্যাথোলজি কি বল? অস্টিওক্লাস্ট টাইপ অফ জায়ান্ট সেল, সিম্পল অস্টিওক্লাস্টোমা। ঠিক আছে, অস্টিওক্লাস্টোমা, বোনের দুটো সেল থাকে, অস্টিওব্লাস্ট, অস্টিওক্লাস্ট। ঠিক আছে, এটা হচ্ছে অস্টিওক্লাস্ট টাইপ জায়ান্ট সেল। এজ it commonly occurs after skeletal maturity in young patient, in young adult 20 to 40 years of age group. Male-female ratio 1:1.5, and the site of involvement, এটা মনে রাখবি, the site of involvement is epiphyseal-metaphyseal region. Epiphyseal-metaphyseal region of a long bone. The most common site is around the knee joint. Giant cell tumors occurs around the knee joint. That means most common site is distal femur, proximal tibia, and then distal radius. Distal femur, proximal tibia, and then distal radius. এই তিনটে হচ্ছে মোস্ট কমন সাইট। আরও সব জায়গায় পাওয়া যেতে পারে। তাছাড়া দুটো কমন সাইট হচ্ছে প্রক্সিমাল ফিবুলা অ্যান্ড মেটাকার্পাল বোন। প্রক্সিমাল ফিবুলা অ্যান্ড মেটাকার্পাল বোন। আচ্ছা, ক্লিনিক্যাল ফিচার্স, স্লো গ্রোয়িং টিউমার উইথ আ লং ডিউরেশন অফ swelling. It is a slow growing tumor with a long duration of swelling. Why? It is a benign tumor. So it is a slow growing tumor. Commonly swelling appears first, then the pain. Pain is due to pathological fracture or malignant transformation. Usually giant cell tumor is also painless like benign tumor. But when pain occurs, you suspect a malignancy or a pathological fracture. But more common is pathological fracture. Skin over the swelling is stretched and shiny, but no engorged vein. আগেই বলেছি যে giant cell tumor is between the benign tumor and malignant tumor. So the skin over the giant cell tumor is not completely like benign tumor. It is tense, it is shiny, it is slightly warm, but there is no superficial venous engorgement. On palpation, there is a bony hard swelling, eccentrically located and slightly warm and smooth surface. Bony hard swelling, eccentrically located. Eccentrically means, yes, outside. It is growing outside. Okay, it is expandile and eccentrically located. It is eccentrically located and slightly warm and smooth surface. Here the skin is slightly warm, but not warm as malignant tumor. But the surface is smooth. Skin over the swelling is free and skin may be involved in malignant transformation. In any bone tumor, the overlying skin is free. But when it undergo malignant transformation, it invade into the surrounding soft tissue and involve the skin. Okay. Another is, এটা কিন্তু MCQ আসে, egg shell crackling feeling. Egg shell crackling feeling. When giant cell tumor erode too much cortex or there is too much thinning of cortex, when you palpate the tumor, there will be eggshell crackling feeling of the tumor. Why? Because due to too much thinning of the cortex, cortex looks, it is so much thin that it looks like a shell of an egg, or due to pathological fracture. But never do in clinical practice, because if you try to elicit the eggshell feeling, there will be chance of pathological fracture, because the cortex is so thin, and if you press the tumor, it can lead to pathological fracture. So eggshell crackling feeling may be there due to too much thinning of cortex or due to pathological fracture. There may be mechanical obstruction of the joint, because giant cell tumor common position is knee joint. So giant cell tumor can also lead to mechanical obstruction of the joint. Distal neurovascular deficit may be present due to compression or malignant transformation. Now, investigation, X-ray features. আচ্ছা, প্রথম তিনটে মনে রাখতে হবে। ডিস্টার্ব করে এগুলো কথা বলুন। আচ্ছা, ইনভেস্টিগেশন, প্রথম তিনটে পয়েন্ট কিন্তু মনে রাখতে হবে। এক্স-রে ফিচার্স ইজ এ শর্ট নোট। রেডিওলজিক্যাল ফিচার্স অফ জায়ান্ট সেল itself is a short note. It is a X-ray features is number 1 E, epiphyseal-metaphyseal lesion. Epiphyseal-metaphyseal lesion, eccentrically situated. eccentrically situated, আর একটা হচ্ছে it is a expansible lesion. Okay, so it is a epiphyseal-metaphyseal lesion. Number one is a epiphyseal-metaphyseal lesion, eccentrically situated. It is usually expanded outside the bone, eccentrically situated, and expansible lesion. It is expanding, so it is a expansible lesion extending up to the subarticular bone. এটা বলে রাখছি, এটা হচ্ছে giant cell tumor. So it is a epiphyseal-metaphyseal lesion. Epiphysis কোনটা? This is the epiphysis. Metaphysis, this is the metaphysis. So this is the epiphyseal-metaphyseal lesion. It is the expansible lesion and it is a eccentrically situated and expansible lesion. Expansible lesion. It is a expansible lesion and eccentrically situated. ঠিক আছে? আর it can reach up to the subchondral bone or subarticular bone, means it can reaches up to the subchondral cartilage, up to the joint. It does not involve the joint, but it can reach up to the joint. Okay. And next, osteolytic lesion with typical soap bubble appearance. Eta MCQ ashe, very important, soap bubble appearance. Osteolytic lesion leads to soap bubble appearance. Acha, giant cell tumor usually do not erode the cortex, but in case of malignant transformation or in case of high-grade tumor, it can erode the cortex. Usually it is confined within the bone, but cortical break indicate more aggressive tumor. Next is the CT scan. CT scan confirms the integrity of the cortex and outline of the tumor. In giant cell tumor, you have to do CT scan because you have to see the integrity of the cortex, how much cortex is left after, in the tumor, because according to the presence of cortex, you have to do the treatment. So it is very important to do a CT scan in a giant cell to see the integrity of the cortex and outline of the tumor. Another is giant cell tumor is very commonly metastasis to lung. The most common site of metastasis to a malignant giant cell tumor is the lung. So you have to do HRCT thorax. HRCT full form ki? HRCT thorax, high resolution CT scan of thorax to detect the metastasis in lung. Or MRI have to do in all bone tumor, whether it is benign bone tumor or it is malignant bone tumor. For morphological analysis and extent of the tumor, intramedullary extension and soft tissue extension. Next is biopsy and FNAC. FNAC, it is a limited role. You can do FNAC from the tumor or biopsy from the tumor. But open biopsy is always superior to the FNAC because you have to see the gross morphology of the patient, and open biopsy you can also take better histological slide. So FNAC and open biopsy. Tale X-ray, CT scan, MRI, FNAC and open biopsy. আচ্ছা, giant cell tumor pathology মনে আছে কটা সেল থাকে giant cell tumor এ? Giant cell tumor pathology একটু মনে রাখবি, it consists of stromal cells. Stromal cell is round to oval or spindle shaped cell contain one or two nucleus. Round to oval or sometimes spindle shaped cell with one and two nucleus. These cells are the stromal cell known as mononucleus cell. These cells are stromal cell known as mononucleus cell. And the giant cell is known as osteoclast type multinucleated giant cell. Osteoclast type multinucleated giant cell, and they contain eosinophilic cytoplasm and numerous number of nuclei. মনে আছে? Osteoclast type multinucleated giant cell which has eosinophilic cytoplasm and numerous number of nucleus. এটা কিন্তু পরীক্ষা ধরতে পারে কি থাকে, এটা হচ্ছে মাল্টি নিউক্লিয়েটেড জায়ান্ট সেল। আচ্ছা, নেক্সট হচ্ছে রেডিওগ্রাফিক গ্রেডিংটা একটু জানতে হবে। সো ক্যাম্পানাসি রেডিওগ্রাফিক গ্রেডিং, ইট ইজ কোয়াইট ডিফিকাল্ট, বাট এটা আমি সবচেয়ে ইজি পেলাম যে গ্রেডিংটা। Grade 1, because according to the grading we have to do the treatment of the patient. Grade 1 cystic lesion, grade 1 টা হচ্ছে cystic lesion বলে দিচ্ছি, এটা হচ্ছে grade 1, খালি একটা cystic lesion আছে, a cystic lesion confined to the bone. Grade 2 expansile lytic lesion with thinning of the cortex but no break. এটা হচ্ছে expansile lytic lesion, expansile lytic lesion with thinning of the cortex but there is no break in the cortex. And number 3 is the aggressive one, that means there is cortical break and the tumor, there is soft tissue extension of the tumor. Grade 3 destructive radiolation lesion, আচ্ছা grade 3 এটুকু বললে হবে, there is cortical break and soft tissue extension. Cটা হচ্ছে there is cortical break, there is erosion of the cortex and soft tissue extension. এই তিনটে গ্রেড একটু মনে রাখতে হবে। Now treatment, tumor, if the tumor is benign and the cortex is intact, mean A and B. যেটা যে টিউমার ইজ বিনাইন অ্যান্ড দ্য কর্টেক্স ইজ ইনট্যাক্ট, সেক্ষেত্রে কি করবি, এই ট্রিটমেন্টটা মনে রাখবি, ইট ইজ অ্যাপ্লিকেবল ফর অল বোন টিউমার, ঠিক আছে, এক্সেপ্ট অস্টিওকন্ড্রোমা। অস্টিওকন্ড্রোমা একটু ডিফারেন্ট টাইপ। কিউরেটেজ অ্যান্ড বোন গ্রাফটিং, কিউরেটেজ অ্যান্ড বোন গ্রাফটিং, it is the gold standard treatment for tumor which is benign and the cortex is intact. Curettage and bone grafting, but it has high chance of recurrence, 40 to 50% chance of recurrence. তাহলে curettage and bone grafting. So another treatment is there that to reduce the recurrence, that is curettage. That means you have to curate thoroughly, meticulous curettage with a bone graft and cortical window. It will reduce the chance of recurrence. আরেকটা হচ্ছে, এটা নাম মনে রাখলে হবে, আরেকটা জিনিস মনে রাখবি, curettage plus bone cement. You can do curettage and you have to fill the bony gap with a bone graft, or you can fill the bony gap with a bone cement. Okay, so what is the advantage to fill the bony gap in with bone cement? That when the bone cement কি হয়, একটা পাউডার থাকে, একটা সলিউশন থাকে, ঠিক আছে, তো পাউডার সলিউশন মেশানোর পর কি হয়, there will be exothermic reaction. So when you are putting the bone cement within the cavity after curettage, there will be exothermic reaction, there will be release of heat, and this heat also kills the tumor cell. So curettage plus bone cement, exothermic reaction kills the surrounding tumor cell. Curettage bone grafting and curettage and bone cement. Achha, other technique is curettage with phenol and alcohol plus bone grafting. You have to do curettage, then you have to apply 5% phenol and 70% alcohol, and then you do bone grafting. Or curettage, bone cement, adriamycin and methotrexate. You can also apply some chemotherapeutic agent inside the cavity. Like curettage, after curettage, you can apply bone cement with adriamycin and methotrexate. Achha, but if the tumor is malignant or it is a locally aggressive tumor, it erodes the cortex. So what will you do? You cannot do curettage. You have to do wide local excision of the tumor followed by reconstruction. এই জিনিসটা কি বলেছি, ধর একটা ডিস্টাল রেডিয়াস টিউমার হয়েছে, ডিস্টাল রেডিয়াস GCT যে ছবিটা ছিল, it is a high grade tumor, it erodes the cortex and it enters into the surrounding soft tissue. So then in that case you cannot preserve the distal radius, you cannot do curettage or you cannot apply bone graft. So what you have to do, you have to remove that distal tumor along with its soft tissue. Distal radius. You have to remove the distal radius, you have to remove the whole tumor, you have to remove the surrounding soft tissue, and then you have to reconstruction the bone with the other bone. যেমন distal fibula-তে যদি এই distal radius-এ যদি GCT হয়, we have to reconstruct the distal radius with a proximal fibula. You have to reconstruct, বলে দিচ্ছি, এই যে এই ছবিটা, এই যেটা distal radius GCT. So you have to remove the tumor, you have to remove the surrounding soft tissue, and then you have to reconstruct the bone with another bone like proximal fibula. Or like আরেকটা আছে যে in case of GCT, কোথায় যে কাজই করছে, in case of GCT in proximal fibula, in case of GCT in proximal fibula, or in case of giant cell tumor in the rib, you can excise the bone. Simply you can do wide local excision of the tumor. That is enough. Or it's a metacarpal bone. If there is a giant cell tumor occurs in the metacarpal bone, because metacarpal is also a common site of giant cell tumor, you can do reconstruction. You can do reconstruction after the wide local excision of the metacarpal bone with a metatarsal bone, and here the third metatarsal is used. এটা হচ্ছে proximal fibula GCT হয়েছে. So in proximal fibula GCT you can simply remove the tumor along with surrounding soft tissue. You can do simply wide local excision. আর যদি metacarpal GCT হয়, you have to remove the GCT and you have to reconstruct the metacarpal taking the third metatarsal bone, because you can third metatarsal bone remove করলে পায়ে কোনো ক্ষতি হয় না. So you can remove the third metatarsal bone and apply in the metacarpal bone. Okay. Another is the, if the GCT occurs in knee joint, GCT যদি knee joint এ হয়, then you have to do arthrodesis. What is arthrodesis? Arthrodesis কি? Surgical fusion of the joint. You can do wide local excision and then do arthrodesis of the joint. But the most common treatment in nowadays in GCT in the distal femur or proximal tibia for an aggressive type, you have to do wide local excision of the tumor followed by reconstruction by megaprosthesis, যেটা এখানে করা হয়েছে. So you see there is a expansal GCT or aggressive GCT in the proximal tibia. So here the wide local excision has been done. You have to remove the whole tumor along with surrounding soft tissue, and then you have to reconstruct the joint, or you have to do arthroplasty, or you have to do the reconstruction of the joint with the application of megaprosthesis. Megaprosthesis মানে কি, যে নি রিপ্লেসমেন্ট করি আমরা, নি রিপ্লেসমেন্টটা হচ্ছে প্রস্থেসিস. এটা হচ্ছে সিম্পল সেই জিনিসই, কিন্তু ইট ইজ মোর এক্সপেন্স, মানে মোর বিগার প্রসেসিস, এগুলোকে বলা হয় মেগা প্রসেসিস. সো ইউ ক্যান রিকনস্ট্রাক্ট দ্য জয়েন্ট উইথ দ্য মেগা প্রসেসিস. ঠিক আছে? আচ্ছা, আরেকটা হচ্ছে, এটা এমসিকিউতে আছে, হোয়াট আর দ্য সাইন অফ রিকারেন্স অফ জিসিটি. একটা জানিস মনে রাখবি ফর এমসিকিউ পারপাস, সিরাম TRAP লেভেল, ট্র্যাপের ফুল ফর্মটা হচ্ছে টার্টারেট রেজিস্ট্যান্স অ্যাসিড ফসফেটেস. টার্টারেট রেজিস্ট্যান্স অ্যাসিড ফসফেটেস. Usually in GCT, the trap level is high. Tartarate resistance acid phosphatase level is high. But when you remove the tumor or when you excise the tumor, it will suddenly drop. But if it reappears, that means there is recurrence of the GCT. So after removal of the tumor or after curettage of the tumor, you have to check the trap level, tartarate resistance acid phosphatase. And in X-ray, for recurrence of GCT, you can see destruction of the bony graft, reappearance of the osteolytic lesion. এটা মনে রাখবি, এক্সরেতে কি পাবো, আবার সেই পুরনো ফিচার্সটা ফিরে আসবে. ধর আমি বোন গ্রাফট ইউজ করেছি, সো দেয়ার উইল বি ডিস্ট্রাকশন অফ দ্য বোন গ্রাফট অর দেয়ার উইল বি osteolytic lesion. Okay, but এইটা ফর এমসিকিউ পারপাস মনে রাখবি TRAP level, serum TRAP level. আচ্ছা, আরেকটা জিনিস লেখা হয়নি, which drug is used in GCT? Which drug or injection used in GCT. হ্যাঁ, এই তো denosumab, high dose denosumab can be used. ঠিক আছে, না বন্ধ করো।